the next session is about chronic disease and active and healthy aging, two big challenges and big topics for each healthcare system. So I will call my colleagues to join me on the stage. You can join here. So we have three very good speakers on this session, as the other, of course. So we welcome Christoph Westerteicher, who is, I would say the exact title you have, the Business Director, H2H TeleHealth International for Philips Medical Systems in Germany. We welcome as well Silvia Cordomí, who is a health economist for the Catalan Institute of Health in Spain here, the local representation, and Dr. James Mault, from Chief Medical Officer from QUALCOMM Life from USA. Thank you to all three. Of course, as you know, we talked about it this morning, the chronic disease are one of the major burden for healthcare systems, of course. Around 75–80% of the health expenditure are going to chronic disease treatments. And active and healthy aging, it means that, well, the demography in whole developed country is what it is, and we have more and more seniors, more and more aged people and aged population, and we have to develop some solution for that. So the idea of this panel was to discuss a bit what are the approach, what are the technology, but not only the technology, what are the process you have to design to reach to results, and we will have in those presentations some results of some experimentation on systems. So we will start just now with Christoph from Philips, who will explain Philips' experience on this topic.
So good afternoon, my name is Chris Westerteicher, and I manage the Philips Hospital to Home Business International. I've given the little presentation that I'm going to do the title Scaling Telehealth. And what I'd like to do, if I can get this thing to work, just press this button here. Ah, yeah. Perfect. What I'd like to do in this little short presentation is first of all give you a quick introduction of what I term to be telehealth. There's a lot of confusion in terminology, so just use this 2-minute introduction to tell you what I see telehealth being. Initially, telehealth was all about monitoring vital signs of people at home. So if you have, for instance, a classical heart failure patient, and the doctors under this audience will please excuse, you would monitor weight or you would monitor blood pressure. For heart failure patients, these people accumulate water in their body, that is in their tissue and in the lungs ultimately, and they repetitively get sent back to hospital. So the initial intent was really to say, can we just use vital signs monitoring to detect deterioration of patients? Can we go to the next slide? Julien, perhaps you can just move this forward to me. Over time, however, what we experienced is that monitoring vital signs is not sufficient. What we actually want to do is to empower patients to manage this disease more effectively. And here you can see an example that the patients actually get educational material or coaching material to take more care of themselves. Now, to put that into an analogy, what I'm actually saying, what is the difference between telemonitoring and empowering patients? If you envision a person walking with blindfolds along the rim of a cliff, basically the guardrails around that cliff is telemonitoring. It's basically supposed to hinder people from falling off that cliff. Ultimately, what you want to do with empowering patients is actually remove the blindfold so that they stay away from the cliff, that they know that this is dangerous. So that's the difference between those two. The third element that I'd briefly like to touch on is mHealth. We use the term mHealth quite frequently in this audience here in this discussion today, but ultimately for me, mHealth is yet another technology to help support people. It's using smartphones or tablets and allows people to be more mobile. But it's not really a new way of measuring or managing people. It's just a different technology being used. So with that said, oops, wrong way around here. With that said, I'd like to take a next step, which is, okay, so what does actually telehealth do for you? And there have been a number of studies in the past years that have proven that the concept as such is actually very valuable. It really helps to reduce, for instance, length of stays. It improves quality of life. It is even economically sensible. Here are 4 examples, 4 studies that have been published. They're available on the internet if you want to go there. One is a KAMA study. It was actually conducted here in the Barcelona region. And what you can see is that it reduced hospital length of stay for people with heart failure by a staggering 73%, I'm sorry. So in general, these concepts actually reduce length of stay. They also reduce admission rates. These systems, however, also help patients to manage their disease state more effectively and improves the quality of life. So again, we've seen from various studies that the quality of life of these people actually increases over the course of using these systems. It also gives the patients a sense of confidence that somebody's actually looking after them. And last but by no means least, the largest study that was conducted in this area is the whole system demonstrator. It was conducted in England, and one of the headlines that was published was that it reduced mortality by 45%. So after 1 year of using these systems, the control and the intervention group had a difference of 45% in mortality. Any drug that you would find on the market that reduces mortality by 45% would be an absolute blockbuster. Unfortunately, that cannot be said for telehealth. It is still a very slow growing market. And part of the reason why that is presumably because there is a certain hesitance within the medical community to embrace new concepts. And I just want to use this headline here to give you an indication. This is a statement by a medical professional saying that despite the value of these systems, they're very slow in terms of adaptation. Now, this is not a statement which refers to telehealth. It was actually published in 1850 by a Sir John Forbes, and he was referring to the stethoscope. So you can see, actually, this is not new. The medical professionals tend to be rather conservative in embracing new concepts. What I'd like to do to bring my little presentation to a conclusion is actually talk about two primary elements that are essential to making telehealth scale. One is the concept offering. What is it actually you're providing? And ultimately, it has to be a holistic concept. It cannot be bits and pieces. It has to be an entire concept. And here I've just picked 4 elements which I think are critical. I'll come back to the monitoring and compliance in a minute. But if you go around in the clockwise here, you'll see care coordination. So this is about bringing the various players into the context that actually manage a patient. It's not just the care provider and the patient. It could be friends and family. It could be the pharmacist. It could be a visiting nurse, who all play a very important role. And if you want to be successful, you have to bring these people into the equation. I've already mentioned the self-management aspect. So you have to educate patients on how they should be changing their behavior. And there was just a word about empowering patients or actually changing behavior. These are all very important concepts in the essence of really providing the system to large cohorts of patients. Data analysis and patient stratification are also very important because actually one size does not fit all. You want to stratify your patients according to their specific needs and provide them concepts that really help them. So then going to the monitoring and compliance part, here it's just a little bit more detail. I've already mentioned that we've moved far beyond going from vital signs monitoring actually to what we call educating patients. Vital signs monitoring can be important. Ultimately, however, the more important part is really educating patients to take control of their disease state. What we haven't spoken about today at all was the clinical side. So actually, what do the care providers see? Here, there is a whole array of concepts. One is actually guideline-based care planning. So to guide the care planner through a session and provide information to the patient when and where they need it. Last but by no means least, I've already mentioned one size does not fit all. Actually, you have to tailor these systems to the specific needs of the individual patient. And that can be a very intense monitoring at the tip of the pyramid. It could equally be, however, a very simple solution at the lower segment of the pyramid. I'll close my presentation here because I just want to make one final comment, and that is technology is not the gating item in this concept. It's actually integrating it into existing care delivery structures. So we've seen too many times over that people have conducted pilots, and as soon as the pilots are over, the system comes to a grinding halt. It is actually how do you integrate these concepts into existing care delivery structures. Together with 5 regions, and you can see the regions marked on this little blue diagram at the bottom, the leading clinical experts in Europe and Philips, we have implemented a program called Advancing Care Coordination and Telehealth. It's actually an EU program. And the idea is to identify best practice. How can you actually stratify patients effectively? How do you have to train your medical professionals to use these systems in a very sensible way? How do you ensure patients adhere and want to use these systems over long periods of time? So we're in the process of identifying how these various regions have used these systems, and I think the final message I'd like to leave you with, we're seeing very promising results in these systems starting to scale up. So we are now beyond the phase of pilots. We're actually seeing these systems being used partially in routine practice. Thank you very much.
Thank you, Christoph. Thank you very much, Christoph. So now, Silvia.
Hello. Thanks a lot for your presentation, because I'm going to talk about one of these pilots, one of these projects in Catalonia. You can see the map over here. Our project is called TeleMac. TeleMac is the short name of telemonitoring of a chronic care patient. And
You have the...
yeah. It works.
The other one doesn't have an icon like this one.
No? This one? It doesn't work. I'm so sorry. As what I'm saying, TeleMac is the short name of remote monitoring, quite blind in using your words, because it's just telemonitoring. And we wanted to try if these processes and gadgets at home help us to prevent some discompensations of the patient, to anticipate changes in the patient's status. The equipment that the patients have at home is a glucose meter, pulse oximeter, sphygmometer, scales, and are connected with M2M, machine-to-machine technology. And we decided to go for two kinds of patients, patients with heart failure and COPD, because we stratify our risk in our population. This is our pyramid, and you can see in white the non-users of our system, of the Catalan system. And as the yellowish color is the patients that we have just one contact a year with the system. And the more red it is, more complex the patients are. And so we decide to go to the up of the pyramid, the more complex patients, and that means to go for heart failure and COPD. So this is our special pyramid for heart failure and COPD. You can see we have a lot of patients in that condition, really severe, more than 2 or 3 chronic conditions at the same time. So we decide to go to the priority given to the chronic, complex and really frail patients. And what we define in our model, we define 12 different programs related with the pathology, and we gave to the patients a tablet, and it depends on the base pathology. We gave them a scale, a pulse oximeter, and so on. So here you have the definition of all the gadgets that they will have in the function of the complexity. We define all the measurements and all the thresholds that the alarms will be managed by the doctors. This is one of the real graphs that the patient will see, and the monitoring way of our patients and the alerts that will be generated. And above all, let me show you the project explained by the patients. The video goes in, please. Will be better explained by themselves.
Todos los días, cuando me levanto, lo primero que hago es tomarme el azúcar y luego ya hacer todas las biomedidas. Todos los días lo hago. O sea, me van controlando, yo voy mandando todos los datos según me encuentro cada día, y entonces me pareció bien, y todo lo que sea, está vigilado y está esto, pues me pareció bien.
Bueno, van vindre un dia unes noies em va ensenyar com funcionava, vaig provar diverses vegades i vaig anar aprenent.
Sí, a través de esto yo me tomo el azúcar, me la pruebo y entonces se lo envío por aquí, ¿ves? Algo así, y ya lo tiene el médico en su ordenador. Cuando el médico, a lo mejor, yo me lo tomo siempre a las 9:30, a las 10 cuando me levanto. Y entonces el médico, a lo mejor, cuando abre el ordenador, a la hora que tenga costumbre de abrirlo, ve la indeficiencia que hay en cualquier cosa, ¿no? Entonces, si ve conveniente, me llama por teléfono. Y dice, Alfonso, ¿qué te encuentras más? ¿Qué te pasa esto? Entonces, esa tranquilidad es la que a mí me da de que si tengo alguna anomalía, corriendo el médico me lo pregunta.
Enseguida está en contacto con los médicos.
This patient, Ildefonso, for the first time that he was really ill, he ate too much, he has diabetes, and the next day the doctor called him back and said to him, what have you done? Because I have seen your levels of sugar are quite high, your hypertension has gone up. And he was so amazed that the doctor knew that the day before he had a party and he ate too much, that he said, I'm down on my knees praying to you, so I'm so sorry, I never do that again. So sometimes it's quite wonderful. You can see these are real patients. They are quite old. They never used this kind of technology before, and they have been doing really, really good. At the beginning, they were in some point scared, but now they are really used and recommending this kind of tablet and gadgets to the neighborhood. And the problem we have now is that we have to say no, because some of the patients of the neighborhood doesn't have the COPD or hypertension and so on. So, what are some figures of our project? At the beginning, we enroll more than 200 patients, but after being trained or being installed, we miss a few patients because some of them say that they were afraid not to be keen on using the technology. Some of them have problems with the 3G connection sending the data, so they couldn't have the telemonitoring system at home. And several of them, because they are really fragile patients, they died. So now we have active 119 patients, men and women 50. And a nice thing to tell to you is that we have more than 70 patients older than 80, and they are using every day a tablet and all the monitoring system. So digital, being digital, it's possible if you are more than 80. Here you have the program, the distribution of the programs. And one interesting thing is that almost all the patients have generated one alert. So it's a good target because all of them has had a variation of the levels of the hypertension or the diabetes. And 77% have generated red R's, above all for heart failure. So heart failure has worked really good in our study. And if you ask them if they are satisfied with the project, all of them said yes. All of them said they are really satisfied. It's really easy for them to use after being trained. So that was really nice for us. But the most wonderful thing is that figure. They say that now they understand better their illness in 70% of the percentage, and they can control better their illness, seeing the graphs going up or down. So for us, it's a good point of view. They also say that the quality of life for them have improved, 70% again, more or less better is 70. and for them it's easier to answer the questionnaires, to watch the videos, and so on, to do the daily tasks, to do the consultation of the preview measurements, to see the graphic. And if you ask the same questions to our professionals, to our doctors and to our nurses, the response is not as enthusiastic. Yeah? Nurses are more enthusiastic than medical doctors. And they say that it's easy for them to enroll the patients, to do the following up, but they say that the project for them it's not good as they imagined before, and it's about of the capacity of change that we have. Yeah? It's more related of the perception of the doctors rather than the results of the technology, because we have seen that hospital admissions have been reduced in the intervention group, and also the mortality has going down in the intervention group. So the results are really good, but doctors still say, let me see what's going on, I'm not so sure that the patients will be better in telemonitoring project rather than doing the following up myself. So you have several patients, even we have a nun in our project, so we have the project all over. Thank you very much.
Thank you, Silvia. And now Dr. Mault from QUALCOMM Life.
I think I'm on this, right? So I don't have to. So Silvia and Christoph just highlighted so many important concerns in this topic. I think for a moment I'll reiterate them. Which is it, this button?
We all have the same problem.
It's a joke of the day.
Yeah, it seems.
So we kind of heard two different things. One is that for whatever reason, we conduct these pilots. And if you notice, these pilots, while they're showing great enthusiasm and compelling results, there's still hundreds of patients. You're not seeing telehealth being performed in terms of tens of thousands of patients in large populations. Certainly we're not seeing hundreds of thousands or millions of patient populations. Why is that? Well, we heard doctors are reluctant. We have to talk about that. When I was a general surgery resident in 1990, from 1988 to 1990, I was an intern and a second-year resident. I did over 200 cholecystectomies, gallbladder operations, and I did them with a big incision called a Coker incision, literally the right-hand side of your rib cage. And then I went into the research lab for 2 years, and when I came out, suddenly not a single gallbladder operation. In less than 3 years' time, it went from an open, put both hands inside somebody's abdomen, to what's called laparoscopic surgery. And if you've had your gallbladder out since 1995, it's almost certain that it was done with a little video camera and a couple of incisions that are less than a centimeter. Now, what happened? Why did suddenly doctors go from making this big giant incision to doing it with a scope? Because it didn't take doctors that long to change. And it had to do with the fact that they learned very quickly that they could do a better operation faster, and it was just as safe, but it was still the same operation. Now, what we're seeing in terms of telehealth, and we'll talk about that in terms of the patient side and the elderly and the adoption of that by seniors and the sicker patients, but then the medical practices themselves, and trying to affect a wholesale change in the way we've performed medicine for 2,000 years. Since the days of Aesculapius and Galen, we as physicians were taught that when a patient was sick, you looked at the patient, you touched the patient, you listened to the patient, you diagnosed the patient. So it's what we call encounter-based medicine, when you're sick, you go to see the doctor, and the doctor sees you. And this is not about technology. This is about an enormous behavior change in the psychology of how we take care of human beings as medical practitioners. And what's astonishing is how many of you flew here to come to this conference? Raise your hand. Okay, keep your hand in the air if you called a travel agent to book your flight to come to this conference. Did you know you can do it online now? But think about that. Think about that. 15 years ago, every one of us in this room would have talked to a travel agent or Lufthansa agent, but not today. Today, every one of us, right now, could pull out our phone and within seconds see every flight back to Frankfurt or to London, and within minutes choose the flight that meets our schedule and pay for it. And no one on the other side had to talk to us to book that reservation. Well, what does that mean? Well, it means it was way more convenient for us, and the airline didn't have to hire 1,000 agents to take each ticket. So the transformation, and think about all the industries, oops, wrong way, all the industries, whether it's shopping or banking or the airline industry, that have undergone, 15 years ago, tell a travel agent that no one will need their services and we can do this all on their phone. That would be pretty disturbing for them, wouldn't it? So there's a lot of doctors out there saying, wait a minute, what do you mean? I don't need to see the patient, and patient's going to get better care than what I've been giving by seeing them in my clinic? How is that possible? I reject that. Okay? And yet, we have to show everybody that this is better care and that the doctors actually can be a part of it. In the United States, for the first time in the history of the U.S. healthcare system, as of January 1st of this year, doctors will now be able to get paid and can earn $250,000 per year new revenue for their practices without ever seeing the patient face to face. This is big. It's the first time ever that you can get paid to take care of a patient without a mandatory requirement to actually see them. It used to be fraud. If you sent a bill to the insurance company and you didn't actually see the patient face to face, you could go to jail until January 1st of this year. That's big. And this is how we're going to transform the way we deliver care from seeing the bank teller and calling the travel agent to doing this electronically. Now, how do you do that in a scalable way? Because frankly, sending somebody to the home is not scalable. That's very expensive. And to train patients how to do these things, that's not scalable. It's too expensive. To make this ubiquitous, to make this on a population level where there's millions of patients getting better care, we have to do this in a completely different way. And this is what's called going from synchronous communication, again, seeing you face to face, to asynchronous. So with synchronous, that means a nurse case manager is either talking to the patient or talking to the pharmacy, talking to the pharmacist or the physician or the family. That doesn't work. It's not scalable, and it's not how even the airline industry or the banking industry works now. And this is going to asynchronous communication, which means multiple parties can communicate simultaneously with multiple other parties. This is called virtual care, and the ability to create a virtual care team of any construct. This is like Facebook. It's like LinkedIn. It's being able to connect with all the people that are involved in that patient's care in a near real-time fashion, near real-time. And then what does that mean in terms of the information? Well, I can't look at 1,000 blood pressure measurements each morning. I don't want to. I shouldn't have to. In other words, the only thing that matters is the fact that everybody's getting their blood pressure measured at home, magically, and the only thing I need to do is see the 20 patients out of 1,000 whose blood pressures are triggering a criteria. So that's called exception management. So what we're looking at here to really transform this whole game is a behavior change that incentivizes taking care of patients without ever seeing them unless there's an exception, right? You don't call the airline anymore. You're happy to not talk to Lufthansa or Virgin or any airline unless the weather is bad and your flight got canceled. Then you're on the phone. You're going to miss your connection. I need help. Okay, that's called exception management. So now we have to immediately pivot to the next concern, which is technology is not going to replace the clinician. The patients don't want robots taking care of them, if I trip. And the doctors don't want to just take care of patients through a computer. Healthcare will always be a human practice. It should be. But what you want is a continuous care model instead of an episodic care model. It's the ability to be plugged in to the people taking care of you, and for the people taking care of you to be plugged into you and to the other parties that are involved in your care, but to be able to bring to attention those individuals that, based on the data, need your attention. So now I can spend more time as a clinician with the patients who really have a problem. And then the other 80% of patients who are fine, guess what? They're happy to be fine. And if they don't need to come and see you every 3 months for you to say, hey, good job, everything's fine, they're probably happy about that as well. And that's how this is all going to work. So it's really moving from a continuous care, from an episodic care model to a continuous care model. Now we have to think about the population. And frankly, you know, you're getting some really nice results, but these people are getting a lot of attention. And you saw the clunkiness of our technology is still in its infancy. We need to get to a place, and Qualcomm is working very hard to help develop even wearable sensors, things that are magical. A senior, even connecting a USB cable into a computer, we learned at Microsoft, was a showstopper. 80% of seniors were calling on the phone for support to figure out where to connect a USB cable. You can't have that in a scalable multi-million patient population. And so we're going to need to be able to do this with seniors across, as Christoph said, a variety of interfaces. It can't be dependent on a tablet necessarily. You might have to do this on a television set, or it might be an IVR system that calls the patient, or it could be a smartphone, depending on the patient population. So we're going to see an expansion, a rapid expansion, and a ubiquity of how we engage with patients on their terms in order to be able to get this information. And in many cases, it needs to be information gained without them even realizing that they're doing something. So wearable sensors and wearable patches, I think, hold a lot of promise in this regard. And then on the clinician side, the ability to aggregate all the information and from a virtual care team in near real time to allow that information to notify you when that patient needs your attention. Now let me finish by showing you something absolutely remarkable. This is a brand new hospital that will have its ribbon cutting opening ceremony in May, just about 8 weeks from now. This facility is a $150 million facility, and it has no beds. If you look at the floor plan here, this is a hospital for doctors and nurses with no beds, and will be taking care of tens of thousands and hundreds of thousands and soon millions of patients from a central location across multiple states in the United States. And these are the stations on which the doctors and nurses 24 hours a day will be reporting to work and taking care of thousands and tens of thousands of patients, both in intensive care units all over the country, as well as inside patients' homes using these technologies. So it's a very exciting time. I think we're in our infancy. We need to think more about the behavior change and the retooling of how clinicians think about taking care of patients and giving them incentives and reassurances that they are still taking care of the patients, but in a very different way. That's actually better for their care. Thank you.
Thank you very much. So we are late, but we will take some questions from the audience. Please. You don't have any question? It's incredible. Incredible.
There's one there.
Yeah, there is one. Yeah, perfect.
Thanks. Very, very interesting. David Somick, European Health Futures Forum. We're involved in the EIP on active and healthy aging, but
can you speak a bit louder?
Sorry.
Please?
The ACT project and the examples locally from Catalonia. Given what we know about the barriers, particularly physician conservatism that you pointed out, what was the driver? Do you think the essential things that allowed you to be successful here?
First of all, the success was that the doctor and the nurse explained to the patient what was going on with this project and so on. So the relationship in between the patient and the doctor was the main issue to the patient to be involved. And the other main issue is that the patient knows that the nurse or the doctor will phone him or her if they are with a problem and so on. So it's quite close to the patient, to the GP team. So for us, it has been the combination of the technology and the personal approach.
Yeah, just take the mic.
What I was interested in is, how did you persuade the doctors to get involved in the first place?
With a lot of money? No.
It's about of money. It's about of doing the same in a different way, and they don't want to change. They consider that the better way to attend patients is the touching, seeing, feeling, and so on. So technology for them is being separated. For the first time that we put a computer in our centers, they say that they can't see the eyes of the patient. So for them it was a real problem. So imagine if they miss the visual contact in a physical space, so now they don't see them, they have to phone or look just to the tendencies of the program. So for them it has been really difficult to lose the proximity.
Other question? Yeah.
Hi, Brendan Fox from the Digital Health Institute in Scotland. I've got a question for James, a very similar question, James. How do you know that your hospital with no beds is going to work with clinicians involved?
The question is, how do you know the hospital?
Yeah, it's the same point that Chris made earlier on with regards to doctors, insisting on face-to-face as the first option. How are they going to adapt, and how do you know it's going to work in this environment, this telehealth environment you've created?
It really is a wholesale retooling of how they approach this. In this organization, it's really impressive. This is a hospital system across 6 states in the United States that has 36 different hospitals, and at the level of the CEO and the entire leadership, they made a declaration, and in the United States, there's a huge change that's taking place going from what's called fee-for-service to value-based care. In other words, very quickly now, instead of every time a patient gets admitted to the hospital, that used to be revenue. Now, over the next few years, by 2018, Medicare has declared that all the payments will be value-based, which means every time a patient gets admitted to the hospital, it's an expense. And so all the hospital systems are scared to death, realizing that the incentive now is not to admit patients, but to do everything to keep them out of the hospital. So at a leadership level, the smart hospital systems are saying, we've got to start rebuilding our clinical staff and our processes and procedures to incentivizing our doctors and nurses to learn how to take care of patients in their home. And they're actually planning they have a revenue forecast of $2.5 billion over the next 5 years from these new telehealth services. And they started in the intensive care unit. So they're actually doing ICU monitoring of patients in 6 different states from a central location. And they're actually getting tremendous results, and then that's going to extend out into the home. But it's a lot of work, but they're way ahead of the curve. They're a shining example of where it's all going to go.
Hi, it's Pablo Caballero from Health and Nutrition for James. In your opinion, which type of organization nowadays are prepared to adopt this new paradigm, this new type of medicine based in a massive, cheaper, more effective treatment of the patients? In my view, are all in the USA, but outside the USA, in a massive way, somebody is adopting this? Thank you.
Yes. I would definitely say outside the US it is also being embraced. I mean, what James was describing, again, it's starting from the ICU, so the intensive care wards where you kind of have, a shortage of staff, in particular at night and on weekends, and this is becoming a very valuable asset. However, in Europe, if you take the UK, for example, if you take the Netherlands, so if you take some of the countries which are hotspots, you will see there is a very strong incentive right now to go from classical, bring them to the hospital kind of concept, to actually managing them remotely. I think to one of the comments which was made earlier on, what does it take to change? My indication, or the key takeaway that I'm going to leave you with, is the system has to change. It's an organizational change, because in all pilots you will always observe, let's say 10% of your patients are managed with these new systems, 90% are managed with the old system. How do you expect to have an organizational advantage by doing it that way? You have to change everything. Yeah. And that's the difficult part. That's the difficult part. But if you can convince an organization to change and to embrace these new concepts, you all of a sudden have a productivity gain. But there are also inherent fears. I mean, James pointed out the fears of the doctors. There is the fear of the nurse, that do I have a job tomorrow, or is the system going to replace me? I think those fears are incorrect, because we have this aging population and so on. But those are the fears you have to overcome. It's not technology. It's organizational change.
And payment.
Last question.
Payment models.
It's more of a comment as a doctor who is also in IT. I think if we will have care providers come on board of such projects, we need to be more creative with our pitch. Doctors are used to being paid for how much work they do. Mm-hmm. And now you're telling them they're going to do less work. Mm-hmm. And if we can do a little bit of work on the pitch to tell them you might make more money, or as I'm sorry, sir, Dr. James pointed out that doctors made more money from not seeing patients. So if we can change the mindset through the way we present the information to them, they might be more cooperative on future projects. Thank you.
Absolutely.
Wholeheartedly agree.
Okay, we will stop now. I'm sorry.
Thank you.
For the question, we will have a coffee break, so we will move on the next session. And thank you very much for our speakers.